I request the next speaker, Dr. Deepika Mishra, to please grace the dais. She is going to be speaking on future of oral cancer diagnosis, artificial intelligence, and machine learning approaches. To chair the session, I call upon Dr. Soumya SV, Professor and Head Oral Pathology and Microbiology Department, and Dr. Pavitra Chandrasekhar, Professor and Head Department of Oral Pathology and Microbiology, KL Institute of Dental Science and Research Center, Bangalore. Good morning, everyone. Today we would like to introduce our guest speaker for the day, Dr. Deepika Mishra. She is currently heading the post of Additional Professor at the Center for Dental Education and Research, AIIMS, New Delhi. Her research interests include diagnostics and oral cancer and oral potentially malignant disorders, artificial intelligence in oral and maxillofacial pathology, bone pathologies in oral and maxillofacial region, odontogenic cysts and tumors. Her significant contributions include developing the Department of Oral and Maxillofacial Pathology, CDR AIIMS, Delhi, as a national collaborating center for generating medical imaging data sets for tobacco-induced oral lesions to enhance research in health in India in collaboration with ICMR and IISc Bangalore. In collaboration with IIT Delhi, she has developed a detection device for screening of oral cancer and pre-malignant lesions. She has also started various services for oral histopathology, cytopathology, immunohistochemistry, immunofluorescence, in situ hybridization, museum specimens, frozen sections, oral cancer detection, autofluorescence, hematology, and oral pathology-based registry at CDR AIIMS, New Delhi. And she has initiated several extramural and intramural research projects in association with ICMR, IIT, AIIMS, and CSIR. She has also been the resource faculty for oral cancer screening at WHO CRO PEN online course for accessibility NCD service delivery in the regional countries organized by WHO. She has also contributed to the improvement of the cancer-related website India Against Cancer developed by ICMR National Institute of Cancer, and has also contributed to e-Dant Seva application under National Oral Health Program, Ministry of Health and Family Welfare. She has delivered several national and international level guest lectures, and she has also been the recipient of several awards at the national and international forums. Today I am very happy to invite you, Dr. Deepika Mishra, for this guest lecture, and she will be highlighting on the topic Future of Oral Cancer Diagnosis, Artificial Intelligence and Machine Learning Approaches. Without further delay, I would like to call you upon, and we would like to hear from you the various insights about AI and machine learning. Thank you.
Thank you so much, Dr. Soumya, for your kind words. And at the outset, I would like to thank Ramaiah, so fortunate to come here and deliver in front of this august gathering. Also want to thank ICT and NAMS for bringing this workshop possible. And most of all, I would like to thank Professor for giving me this opportunity to be here and speak about this this topic which is very close to my heart, and I think so this is the area which nowadays has created a lot of buzz in the research field. So what exactly is the future of oral cancer diagnosis, and is there any role of AI, ML or artificial intelligence or machine learning approaches? So let's see what's the evidence so far. But before we begin this journey, let us understand why this oral cancer is something which we need to talk about so much, because we live in India which is now showcasing maximum cases of oral cancer in the world. When we talk about men, so it's the most common cancer among males in lip and oral cavity cancer, especially in the gingival region where most of the times they chew and keep the tobacco. When we talk about Asia, again India is one of the highest incidence. And globally, Southeast Asian countries again shows multiple cases of oral cancer. So So I call it as India's disease. If you see, compare different types of cancers, lip and oral cavity cancer is the top among males and second most common among both the genders. There's the recent Globocan 2022 where it shows approximately 1.5 lakh cases of lip and oral cavity cancers per year. Out of which 80,000 approximately cases succumb to death. So that's a huge number of cases. So we can see the prognosis is really poor for these cases. And why, as a dentist, we become very important because we can catch them at a very early stage, or especially when they are not transformed into oral cancer, when they are just oral potentially malignant disorder. And why it is so important for us to deal with this? Because there are a lot of challenges which are there. If we see that there is a growing burden of non-communicable and communicable diseases in India, and there is a lot of disparity among, the healthcare workers, still there is a shortage of doctors and other paramedical staff in the rural areas or underserved areas. So apart from that, there are financial constraints, urban-rural disparities, and shortage of healthcare professionals. So we need to also understand that now it is affecting more of a younger age group. So, and those are mostly the earning people in the family. So we need to really understand that this is a disease which we all have to come together and fight against. The best part for this oral cancer is it always it's like more than 80% of these cases they progress from oral potentially malignant disorders to cancer, which could be seen easily in the oral cavity. So there are certain signs which the white and red patch as we can see clinically, and then when we subject them for biopsy, you can see certain changes in the slides as well. And those are the characteristic features which you can identify. So once if we can see them clinically, in the image, if we can identify, so a similar thing, a hope lies there that can AI/ML also, if we train it to image-based modality, can it also identify or at least help the doctors not to miss out such cases, or also help in paramedical people to send them to a tertiary care immediately. So just before embarking on AI/ML, just to give you a brief idea what exactly is AI. So AI is a broad field of computer science for creating systems capable of performing tasks which is mimicking human intelligence. Which means something like a reasoning, learning, problem solving, so all those capacities which human intelligence shows. So that's a broader field is called artificial intelligence. A subset of AI is machine learning, which focuses on the development of algorithms. So it's that make predictions. So how we decide that this patient has more chances of turning into malignancy. So those predictions or algorithms are the component that is called as machine learning. Then neural network. So the term neural network has been derived from the neurons which exist in our brains. So it's a model within machine learning that simulates brain-like processing. So it works. They have different networks which work together, and the information is processed, and then it gives us a sort of actionable point. So those are the neural networks. And then there's something called as a deep learning. So you can actually understand that deep learning is something like our subconscious mind. So how sometimes we just have a notion that this is right and this is wrong. So the same thing happens with the deep learning. We don't know how it works. It is based mostly on the neural networks, but it analyzes complex patterns in its own way and gives an answer. So that's deep learning. So whatever data you get to an AI or a machine, and similar would be the output, which we want that it should be able to diagnose, it should be able to predict. So we always say, can AI predict something like whether this case will turn into cancer or not? So the entire answer lies whether we have taught them well. So it's something like how a resident would perform. Have we really taught them well that they can perform well? So it's a similar kind of thing. We always say that garbage in would lead to garbage out. So if you put in good data, you'll get a good output. So this is just to depict how these all AI ML are being used in different modalities like precision oncology, like to predict the treatment outcomes, then drug discoveries, then imaging and digital pathology. So nowadays there's a earlier there were some sort of myths that is there AML going to replace the pathologist or the doctors? But now it's something like is the AI ML compatible pathologists are going to replace in long term AI ML not compatible pathologists. So I think so it's going to sort of bring a lot of transformation in terms of learning. And also the accuracy and efficiency which has been, which AIML has added. So that the pathologists can focus more in accurately diagnosing and also focusing on the right cases rather than wasting their energy on maybe something which is really not required. Then AIML gives us a leverage of, sort of collating all the data. For example, we are getting a lot of genomics data through next-gen sequencing. So this AIML just doesn't work on only image-based. We have a provision of always, sort of associating it with the genomic data, the metadata we call it as, the clinical data, what were the high-risk habits, what was the radiology imaging. I mean, everything comes together. That's the prediction modeling it does. So sometimes, like we talk about the dermatology department, there in Australia, they have almost superseded the dermatologist diagnosis. So they have this kind of now, rules coming in that whenever you diagnose a case, have you really sort of followed the AML prediction modeling? Because that's what they have seen, that when they have compared the opinion by AML compared to the dermatologist, it has exceeded. Because that is trained on the pathology-based data, along with the clinical data. Whereas many a times, as a clinicians, when we learn in our process, is sometimes only on the clinical data. So a similar thing is coming in the pathology department as well. So how does it learn? They have three types of learning. You have supervised learning, unsupervised learning, and then reinforcement. So supervised is something like you label the data, you annotate, you label it, you tell, okay, this is a cancer, this is a non-cancer, that's a supervised learning. Unsupervised learning is you do not label it, but you just give the structured data and then it learns by itself. Of course, it requires a huge data for the unsupervised learning to happen. Now we have transformers coming in which is dependent on supervised learning. But of course, first you require a label data to train, and then the unsupervised learning can happen. Then there's a reinforcement. So it's something like a decision process or a reward system. So you give a data, they will give a prediction, and then you reward if it is correct. So it's something like that how the AIML works. So what exactly is the application? Now ML has been, mostly when we say AI, it's actually the ML which we are mostly indicating. So what is this machine learning? It's mostly now being explored for early detection and screening. Especially the images are being used for deep learning so that it can detect early signs. It can be used for histopath analysis, like you have, it can identify those cancerous cells, and you have a convoluted neural network which enhances accuracy. Then of course there is a prediction modeling, and also it can contribute for the prognosis and treatment plan. The key technologies are other than supervised and CNNs. There's also something called as support vector machines. We call it as SVM. That is mainly employed for the early detection models. So what exactly is the accuracy of the algorithm? So that's been predicted by support vector machines. And then you have natural language processing. Is it the one which AIML can actually use, or is it has to be slightly changed accordingly? So that's the important thing which we need to understand, that the data has to be made so that AIML can contribute. That's called as a good data. So how you acquire data, how you prepare it so that AIML can work on it and you get a good algorithms out of it, or you get a good, you get a good answer. So it all depends how you're acquiring the data, so therefore the SOPs, what is the equipment you're using, what is the protocols which comes in, are you doing a quality check for whatever you're gathering and feeding in for the model training, and accordingly you will get the output. So these are the, so there is nothing like, this is something new. There are good evidence wherein they have sort of explored in the sample images and they have tried to classify between normal versus cancer, and how they do it. You take the images, you pre-process them, you subject them with various multimodal algorithms, and then it is subjected to CNNs, which is a fully connected layers, and then it can classify into binary, normal or cancer. Similarly, there are certain deep extracted features which goes into machine learning, which again is leads to the classification, and ultimately we use SVMs or support vector machine for model evaluation. Now the SWIN transformer network is coming in, because but it requires big data, which can actually work without in an unsupervised learning. So you just keep pulling in your data and it will start giving you an answer. So what is the potential role of AI in cancer diagnosis? So one thing is, of course, the diagnostic test. It can be used for diagnostic, alert system, for example. It can help triaging which patients. So we can give an app to a ASHA worker or ANMs and can help in triaging. Okay, which patient should be referred and which should not. Sort of exert the tertiary care center, so it can triage there itself. Then it's going to lead to a lot of transformation into a digital pathology or telepathology. So, of course, with the platform coming in, we have a lot of omics data which can also get into the system along with the image data, which can enhance the accuracy and also can help in prediction modeling, which patients might have increased chances of turning into cancer. And then when you have the AI, and then it just doesn't work only on image. You have the biomarkers, the other parameters, which can also be pulled in and can be associated with it. It can also help in prediction and prediction modeling, and also stratify the screening. This is led to digitization of many of the healthcare sectors, and also it can help in decision making for the general practitioners. So what are the stages of an oral cancer patient in terms of AI? So these are the 4 stages. So when we talk about oral cancer screening, it starts from the low resource setting, wherein the ASHA NMs are sending to the frontline workers, health workers, who can have some sort of device which can capture, and those could be a white light images or could be associated with a person's or a person's imaging, which can be transferred to a remote specialist who could be sitting at maybe Delhi and can tell that, okay, this is a cancer or this is not a cancer, and send a message back that this patient needs to be immediately referred or should be referred to a district hospital for the biopsies. Second thing is the specialist diagnosis, which is there could be an on-site specialist, and all the diagnosis could be compared with the ground truth, which is histology diagnosis. So this is one of the very landmark paper which has compared the point of care device for early detection, who has found that the remote specialist, they perform better than the on-site specialist. So that brings even more, that makes your AI even more important. That's a kind of app which should be there for the frontline workers. So when we talk about supervised learning, this is how we annotate the image data sets for the clinical. And these are the different kind of studies, a lot of studies which have been done who has compared the sensitivity and specificity regarding those image data sets. One such work we have conducted at MCDR also, where I would like to also thank oral surgery colleagues who have done the biopsy guided the biopsy which was guided by the autofluorescence spectroscopy. So we identify the lesion, but as we can see in the clinical image, it's a big lesion. So sometimes there is a confusion from where to take a biopsy. So in that case, this autofluorescence and fluorescence spectroscopy can be slightly helpful. So not just the fluorescence which it exhibits in the blue light, but it also gives an objective reading on the spectrometry, which shows that there is a red shift. So whichever area shows a red shift, we get a biopsy from that area. Multiple such devices has been developed by IIT Delhi and teams together. And now, earlier it was validated at our center, and then followed by the margin assessment from cancer center, that's IRCH, for the cancer patients, and now it's being used for the outreach camps. So following this, recently we have started working for Arogyam R1 app, which is being developed in collaboration with IIC Bangalore, who has actually developed this app for the frontline workers, which can immediately, within 2 minutes, can capture all the details. It takes the image and tells whether those images are suspicious or non-suspicious, and is being sent to a remote specialist who gives an indication to the frontline workers that has to be immediately referred. These are a few of the results of the fluorescence spectroscopy work which we have done so far, and this is a multimodal device. So it works on imaging of autofluorescence, fluorescence, as well as spectroscopy of both fluorescence and autofluorescence, and also white light imaging, and combined. And when it has taken multimodality into picture, it shows a very high specificity and sensitivity, of course. So which is 100%, but specificity is also quite high, which is 95%, because it works on the principle of optics. So that has given us a lot of hope, and that's why we have gone ahead, and it has also developed a portal of entering all the details of the patient, spectrum, and the image analysis, ultimately generating a report, which can be deployable at the district hospital where the dentist sometimes have an issue in deciding from where to take a biopsy. So this is going to be a biopsy guiding device, which will be deployable. Now, coming to the next, how AI in oral cancer for the histological diagnosis can it aid in it? So now we are entering into an era of digitizing all the slides. So once you digitize, it leads to a very big data wherein you can identify the cancer malignant cells, which can be annotated and labeled and feed into the system. So this is how we do our annotation, and we sort of train, we extract certain features, subject them for the machine learning, which can lead into the displays on cancer. So these are some of the overviews which has shown that it is now increasing the accuracy that can exceed the abilities of human judgment. So making it quite dependable in times to come. So how it works? You have the digitized slides, you have certain other parameters which can also, like a genomic data, so omics data which can also be included into it, and then AI can sort of give you a guidance. The very basic thing which it can do is, it can sort of tell the pathologist that these are the areas which are look suspicious, so we should not be missing out on those cases. So that really helps the pathologist, and a similar kind of work also do exist for the radiology images, for the CT and MRI, wherein they have seen that AI/ML has been used for finding metastasis in lymph nodes in many cases. Again, it works on the same principle of CNS. But we talked about the medical imaging gold standard data sets. So that's a MIDAS. That's a platform which we developed with ISC for the oral tobacco-induced oral lesions, and wherein it's like a hub and spoke model, wherein other institutes act as a spokes, and they submit their image repository data to our center. We also do a quality check, which is like a pre-artificial intelligence checklist for the image quality assessment, whether this data is like really a good data which can be used for AI/ML. Of course, one is image quality data, whether our SOPs and quality is in place. Second is the lab quality assessment, which also requires some sort of lab assessments. One of it is NABL recognition, which again our center has got it done. So when you talk about this data, the first and foremost thing is are you handling it properly? Because a lot of, now we have a Digital Person Data Protection Act 2023, which is already an act in India, which makes sure that, any kind of data, it has to be well protected. So what do you mean by that? It means that it has to be completely anonymized or pseudonymized, so that all the patient identifiers are completely removed before it is being used for the AIML. So it is, so that's the call of the, again, it requires a lot of checklist and algorithms to make sure that your data is completely de-identified or anonymized, and then you categorize into different categorical data, and that ensures that your data is well protected and the doctors are safe. So we also have developed certain ontologies, which are SNOMED or ABDM compliant ontologies. Why do we need it? So while annotating it in the platform, we need to follow certain ontologies which are like a WHO terms. They are similar to it. So they should be globally accepted, whatever ontologies you are using, and also AI interpretable. So we mostly, while annotating, we try to stick not to use your own words. So we first develop them, we make sure that the platform integrates it into the annotated tool, and then you start annotating it. So this is how we annotate using overhead viewer, and that's a goal to generate a sort of report wherein you can actually incorporate the pathology as well as generate the reports accordingly. A byproduct which happened with all these technologies coming in is the telepathology platform, which automatically, once you have a digitized, you are open to take expert opinion from global experts. So it has made things very easy on both the sides. So you can also give opinion to the centers who do not have this expertise, or the facilities which are there in the tertiary care centers. So this has actually made it possible that there could be one pathologist sitting at one site, and there could be a remote site in some underserved area, and you can always help them and give them the diagnosis. Now coming to role of AI in cancer treatment. So this I'll just shortly touch upon. So when you talk about different type of treatment, so many times we ask the algorithm to tell us, can you predict whether this case would turn into cancer or not? So have we given the right kind of data to the AIML? Have you told them which cases has shown transformation, or what kind of treatment they have undergone? So when you talk about the prediction modeling, you need to give the same kind of data, whatever answer you want the computer to answer. So that requires whatever data patient is, the follow-up of the patients, immunotherapy, the targeted therapy, and then the sky's the limit. Whatever data you keep feeding it will start showing its prediction modeling and self-training itself. So it definitely can help in, deciding the treatments. So there are certain decision support tools which can be formed, which would be much stronger than just the clinical or just the pathological base, because this will combine both all the modalities together at one platform. Then there could be AI promises to reduce radiation exposure, so it's like it enhances image quality. So sometimes suppress artifacts, so it has actually done a lot of good quality check for pathology cases as well. Then there could be certain segmentation which we use, which can also help in treatment planning or triaging. What are the patients which needs to be treated first, and what could be at least dealt with after some time. And yes, so it requires, it also helps in prediction of the response to the treatment by feeding in all the data. So AI in oral cancer follow-up, we know what is the right now the survival rate. So we know that most of the patients in Indian scenario, they report at the 3rd or 4th stage, and the prognosis is less than 20%. So we see approximately 80%, they do not survive more than 5 years. Whereas when we talk on the first stage or second stage, if we can detect them early, it can really help. So we require a proper follow-up, and what they have seen that multimodal AI-based pathogenomics improves survival prediction in OSCC patients. So once you have a genomics data, and you link it with the clinical histology data, it would be definitely more stronger than only histology data, because what happens is you still have a limitation that whether this patient would respond to the therapy or not. So once we have this kind of data, we have a genomics data also linked into it. There's something called as spatiated transcriptomics, wherein it can link the histology slide with the genomics. So once you keep feeding in the data, the computer can start learning by itself, and later on, still that's something which is ongoing research, that only with the histology image it can predict that the patient's genome would be like this. So that's something which is again in the research now. So these are the different kind of data sets which could be used, starting from the very basic clinical image, using proper guidelines, then combined with the histology, your IHC, the molecular, and once you keep pulling in all the data, there are certain models which are already there in the text and the literature which we use, because of which even for the ROAS app, we have used those models in the back end. So when the ASHA worker or frontline worker is taking the image, there's an algorithm which is working at the back end, and the moment you submit, they get a, they immediately get an answer whether it's a suspicious, non-suspicious, and with what confidence interval. So these are already certain algorithms which are already there, which works on the training, validation, and testing phase. Mostly are the CNN models, which are just a neural network. So these are the most older ones which have been existing. Now the recent ones are the recurrent neural networks, so ones which can help in predicting disease progression. They are much ahead of, or sort of replacing now the CNNs. And now you have a long short-term memory, and a short-term memory. So they are again based on prediction modeling. And these are something, the newer terms which have come in, like the graph neural networks and cell graphs, which I told about the spatial relationships. So what it does is, this is a normal histology slide wherein you see a nucleus and the fibroblast. So you just annotate, tell the computer that okay, this is what these cells are, and then the first one we mark the nuclei. The second one we can mark. It forms its own cell graph model, where it measures the distance of those inflammatory cells from the epithelium, the interface, and then it predicts its own, it has its own prediction modeling, how exactly this case is going to progress. So that's called as spatiated transcriptomics. And when all these data, they get into, into one platform, they can help in predicting the outcome of the disease. Of course, they can be used now for the survival-related patterns from histology images as well. So these are the work which is already in research mode. Another thing is the cross-cohort aggregation. It's something like a cross-modality integration, wherein we call it as a big data, which can help in when we combine all the different types of data like epigenetics, imaging, together with genomics data. It can help in clinical decision, new therapy involvement, development, and so on. So these are the translational values we talk about. We do know now that the machine learning and AI, it has its own way of learning, like the pattern recognition, behavioral analysis, which can help in maybe diagnosing and can assist radiologists, pathologists, as well as the physicians in sort of deciding how to follow up those cases. Now, when we talk about what are the challenges we faced, first and foremost thing is protecting the data. So, are we following ethical guidelines? Are we taking patients' consent? Because now we are talking in the era of DPDP. So, are we taking proper consent? Are we completely anonymizing, even after taking consent? Then, whatever algorithm we are developing, is it biased towards one population, or is it a diverse population which is being used? So, we need to make sure we have a diverse data set so that we can overcome that kind of challenge. That's why we always emphasize that the answer of AI ML or the answer of this colon cancer disease should come from India. Otherwise, the algorithms which are developed in the West might not work in an Indian scenario. Then there are certain human versus AI legal liabilities. So you would face many of your colleagues having those kind of myths where you need to sit together and all of us has to be on the same page before deciding how to go ahead. So to conclude, I would like to say that AI does assist clinicians in diagnostic process, and something like a deep learning is nowadays very promising. It is enhancing, showing more accuracy for the early detection of colon cancers as compared to the ML. Now it also represents the opportunity to develop newer technologies. So that's why we see a lot of nowadays grants coming in for AI ML, because that's something in India we have got a huge data. We just have to make it the structured data which could be AI ML compatible. And of course it can predict the course of precancerous and cancerous lesions, as the literature evidence has shown so far. So the road ahead is to enhance these services so that we can cover the underserved areas, also develop certain modalities like mass screening tools, because we do understand that rural and urban disparities do exist. And of course with AI and then the global collaboration has become even more necessary. So with that, thank you so much.
Thank you, madam. That was an excellent presentation. I totally agree with you. I'd like to say one thing. I think the only thing in life which is constant is change. So we as oral pathologists, though we are trained to the regular slide, block, the microscope, I think we also need to adapt. I'm very thankful. I'm associated with Dr. Praveen. Because of him, I got associated with the MSMF, wherein we do a lot of the research work, what you just spoke about, the digital pathology, the wide range of data. We get data from Dimapur, we get data from Varanasi, from our own Karnataka, and so because of this, there is a huge change in there is a huge data network what we see. And one thing I would like to really tell the young people is that there's a lot of scope in research. You just need to apply yourselves, because there's a lot of things to learn, be it your AI, ML, or there are several ways in which you can learn. You just need to apply yourself or focus on it, and which will give you, because even when we were postgraduates, when I was a postgraduate, I didn't know the term AI. To be very frankly speaking, after my son went to school, when he spoke about AI, I said, what on earth is AI? And then when we started doing the research, I learned more about it. And me at this age can learn, and you guys are still young, you're the future of this country. You guys need to really apply this and learn. And one of the biggest and probably one of the greatest role models is Dr. Deepika Mishra. I mean, she is a pioneer in AI in oral cancer pathology. You can probably call it the textbook of AI in business. I'm so glad to have met you and interact with you. Thank you.
Thank you, Dr. Deepika Mishra. It was indeed a very wonderful presentation. Just have one query, since we have huge data that we are going to be using during these research projects, so how do you address the storage issues of these data? What are the measures that you have taken at your level?
So that's a very important question, I would say, but so that's something which we need to actually, that's what I was saying, that we need to have infrastructure ready beforehand, because it's an era of AI ML in years to come. So we need to have an infrastructure so that we have a good storage capacity, and of course there would be a good funding which would be required. We could manage it through a research project, wherein we could get certain infrastructure and servers with us where we can store all this data.
So cloud-based storage?
No, it's we have not got that cloud-based storage because again, for the DPDPR thing in place. So being an old cancer hub, we have got our own hardware servers wherein we are storing the data for us as well as the spokes. So that's something, but It doesn't require too much of a space now. We have got very good desks which do not have a lot of place. They do not require a lot of place. Yeah, there has to be certain funding which has to go.
Thank you so much. If the audience have any questions?
Well, as a clinician, how can we use this AI right when we look into the mouth, specifically the oral care set? How can we use AI? I see 1 million, but I'm not sure. So can you just guide a little bit that?
Okay, so I think so that's something which now we have learned to explain is whatever question we are going to pose to AI ML, first we have to feed in with the answer. So if you want that AI, the AI ML should tell this patient has a cancer or not, have we given the right kind of data sets to it? So that's primarily we have to take a lot of image data sets of the same kind of patients. So annotate, tell or teach the AI. It's like a third class student, you have to teach them, okay, this is how it looks like a cancer. And once it has got a good training, then it will be able to give you an answer similarly. If you want a ready-made material, so now still there are few tools which are coming up. Still nothing is in commercial mode. This is again, the RUAS app is being developed for the frontline workers to be incorporated into NPNCD program. So that would be, maybe from the Government of India, it would be freely available in some times to come. But as of now, I think so if we have to start developing, we have to build up those data.
Sure. Thank you.
So there is this tiny project which we do in Dimapur, wherein we train the ASHA workers, as Madam suggested. So they take a photo and they send those photos to the specialist sitting somewhere all over India. So that researcher goes through, that specialist goes through the image and then he says, this could be so and so, it could be, probably it could be hyperkeratosis, whatever the type of dysplasia here. Based on what the diagnosis the clinician gives, the patient is further sent to higher modes for whether it's biopsy or any other kind of modes. So it's the simple photograph with your AI technology or telepathology which is helping out right now. Yes. Thank you, ma'am.
The clinician is going to have a look and then give so the clinician is going to have a look at the biopsy or the X-ray.
No, so the clinician is not going to look at the biopsy. The clinician is just going to see the image which is sent by the ASHA.
But there would be a self-bias in the clinician seeing it itself, right?
So maybe I'll just add on to her thing. So that the same thing which works on RUAS and app also. So what they mean is, ASHA worker will take the image, will send it to the remote specialist. So the remote specialist is maybe a pathologist or a medicine radiologist or a surgeon, public health dentist. So they are sitting in at AIMS and they are saying that, okay, this looks like a cancer, immediate referral. This looks like a suspicious lesion, can be referred to for biopsy. And this instruction will go to the ASHA worker down the lane and they'll get the clear-cut instruction, refer them or call the patient for follow-up. So, and this could be a specialist who is sitting.
But on a philosophical level, it's on how you look at it, right? Maybe you miss out on
Yes.
the dysplastic cells and the normal cells, and maybe you don't see it. It's the clinician, whoever is seeing it. It's not as in, I mean, again, the person, whoever.
Correct. So all those challenges will come. So once you have the AML, it will have its own challenges.
So
and then we have to deal with
humans are making errors. How do you think that AI could be better than them?
So you have a SVM, which is a support vector machine, which gives accuracy, which gives a sensitivity. So till now, I think for that model, which Madam is also talking about, has somewhere around 85% of sensitivity. So, for these kind of apps, we need to have a high sensitivity so that you do not miss out on the positive cases. Even if you send a false positive, it should be fine, but we do not want anything to be missed. But yes, it will have its own limitations, like the lighting.
Aren't we going to scare the patient if we are going to give them a false positive?
Yeah, so that would come with its own, I think so, but again, another guidelines of how to interpret, how to use these AIML along with the clinician's own judgment.
See, at the end of the day, we won't go taking the photo. The ASHA worker will be trained. She knows if it is a white patch or if it's a leathery lesion or if the patient is not able to open them up. The ASHA worker also would have undergone basic training for which image or which photograph of the mouth has to be taken. She won't just randomly go open your mouth and say take a photograph because I like it. So at the end of the day, so the ASHA worker's competency is also increased. There is a regular training basis, oral cancer module training that we do, wherein we train the ASHA workers or your power karmikas in BBMP. They were given the training saying that in your family, if you see some white thing, in anybody, take a photo, send it to us. Understood? So at the end of the day, there is, the OSHA worker will not go and take a photograph of a healthy mucosa because the person will be trained at the end of the day. Probably not the technical terms of dysplasia or carcinoma in situ or anything like that. But they'll know, boss, this is wrong or this is something weird in this or this is good. So that basic, judgment would be given or the training will be given to the ASHA.
Thank you, ma'am, for your valuable inputs. I now request Dr. Soumya and Dr. Pavitra to kindly hand over the certificate of appreciation to Deepika ma'am.
Professor and teaching guide, Ramaiah Dentistry and Endodontics. He is a professor at Ramaiah College of Dental Sciences, Bangalore. He is a renowned consultant practicing exclusive aesthetic restorative dentistry and endodontics. He is a specialist with the major hospitals like Aster CME, Manipal, Columbia Asia Hospital, Wokhad, Confident Hospital, Apollo, etc. He is a graduate from KU Dental College with distinction and bagged the second rank in the Karnataka PG entrance, completed his post-graduation from SDM College, Dharwad. He has also completed his DNB degree from the Ministry of Health and Family Welfare, India. He has delivered several discourses and conducted many safety programs on endodontics and aesthetic dentistry. He has contributed to several textbooks and has numerous scientific publications to his credit. He is the KOL for different dental companies including Dentsply and has various patents to his name. He has been felicitated with several awards including the Health Icon Award for Best Outstanding Endodontist and Aesthetic Dentist and Academician of the Year. Over to you, Ravi.
Right. Good afternoon, everyone. I think we are close to lunchtime, and I think everybody is more interested in lunch. So obviously, that's understandable. Good afternoon, everyone, and I'd like to start by thanking Ramaiah University as well as the ICD as well as NAMS, along with Principal Sir, esteemed Principal Sir, and NAMS for introducing me and having me in this platform. It's a privilege and an honor. Thank you so much. So, just to understand, how many over here are undergraduates? And how many postgraduates? And the rest are practitioners? Yeah, and faculty, right. So I think we have a higher percentage of undergraduates, and that's what I was made to understand. So the focus of today's lecture is towards actionable aesthetic dentistry, right? So we're going to look at what are the various aspects of aesthetic dentistry and how we can actionably implement it in our practice on a day-to-day basis. So I'm going to keep the lecture more towards understanding of clinical cases and not as much towards textbook, because that is something that you have your esteemed teachers to already impart a lot of knowledge to you. Right. So coming to today's topic, white. White is the color of beauty and purity. White is the color of authority. White is the color of natural beauty. And white is also the color of our teeth. Good afternoon, everyone, and welcome to today's discussion. And I'd like to call it a discussion because I'd like more of interaction rather just a one-sided, lecture on aesthetic elixir, looking at contemporary clinical perspectives to elevate cosmetic dentistry. Now, why did I call this an aesthetic elixir? Now, elixir, as if you're familiar with Harry Potter, a Harry Potter fan, right, you will understand that an elixir is a special magical liquid, a potion that as soon as you have it can magically transform the person into something totally else, right? And believe me, aesthetic dentistry, aesthetics in dentistry and aesthetic dentistry has the power to do that. It can transform a patient's life not just physically but also psychologically and socially, and its impact and its power on a person's psyche has been highly underrated and under-researched, right? The way that you can transform a person, yes, as dentists we relieve pain, that's our primary focus and goal. But when you can transform a person's life through simple and actionable treatment plans, that is when you will feel the power and the magic of aesthetic dentistry, right? So that's why I believe it's an elixir, and I believe that we can use this in our day-to-day practice. So we are looking at the flavor of the season is Olympics, right? We looked at Olympics just now where India won a few medals, and now the Paralympics. So what I'm going to do is structure this lecture on the science of Olympics, right? And we're going to look at aesthetic Olympics, that is, we're going to look at the 5 rings of the Olympics, which stands for the logo, and how they apply to aesthetic dentistry, right? So what are the 5 rings that I feel get together aesthetic dentistry in modern day practice? And I feel it's these which we're going to look at, some a little more, because I feel that I'm going to concentrate more on things which are often neglected and minor aspects of aesthetic dentistry which are often overlooked, right? And those 5 rings I believe that come together are bleaching, a highly ignored specialty, direct and indirect restorations, a huge plethora under them, the use of artificial intelligence and tech, which is fast becoming the mainstay of aesthetic dentistry, right? Interdisciplinary smile designing, which of course is the mainstay of aesthetic dentistry, and the emerging branch of facial aesthetics, which is fast changing the way that we dentists approach the entire face and not just the mouth, right? So let's look at these different aspects. Now, how many of you remember this ad? Which ad was this for? Excellent, I think. And how old do you think is this ad? It's decades old, right? But yet everybody remembers this ad. Why? Because it tapped into a very innate and untapped potential of the human mind, that is to look good. And with that simple ad, that dazzling smile, it captured the imagination of millions of people who still remember this particular ad, right? And that's what aesthetic dentistry has the power to. But from these simple origins where aesthetic dentistry was not even well understood as a specialty, we have now moved on from this happy dent era to the digital workflow era, right? The digital workflow era, of course, is fast evolving in aesthetic dentistry, but I would still say that there is a lot that we have to still do manually to achieve this digital workflow. Right from acquisition, when facial scanners are fast becoming the go-to, the highest standard for aesthetic dentistry, where they work on photogrammetry as well as stereo photogrammetry, right? That's what we're going to use now. We're using intraoral scanners, CBCT, virtual articulators and phase boards. We are processing this information with artificial intelligence and machine learning, processing algorithms, mesh programs, and 3D and 4D photogrammetry, and then delivering it with 3D printers, CAD/CAM, and so many other things to come. So this is a modern trend towards which dentistry is moving. But we are going to go back to the basics and then come back to this. So aesthetic dentistry, as we all know, is an amalgamation of multiple branches. Pretty much every field of dentistry put together contributes to aesthetic dentistry, right? And there are the stars of aesthetic dentistry. All the major treatment plans: bleaching, direct and indirect tooth color restorations, inlays, onlays, and the fancy new terms: overlays, tabletops, wanlays, veneers, aesthetic post and cores, all ceramic crowns, smile designing, the pink, white balance, and facial aesthetics, right? But the stars are nothing without the supporting role. Just like in the Olympics, you have the star athletes, but it's the support staff that make sure that these star athletes perform to their potential. That is the supporting role of various particular. And of course, we don't have the time to go into all of them, right from diagnosis and treatment planning, mock-ups with silicon index, pain control, isolation, magnification, shade matching, impressioning, retraction, occlusion. Believe me, each of these is a day-long or rather even an Olympic-long seminar. Temporization, instructions, photography, software and AI tech, and advanced training, all of these go together. So let's look at first things first in cosmetic dentistry. And what would you say is the first most important thing in cosmetic dentistry? What would be your answer? What would you think it is? Any answers? I'm sure everybody here has done cosmetic dentistry, is doing cosmetic dentistry.
It should be natural.
Excellent, of course. Yes? Sorry?
The patient's preference.
Wonderful. That's exactly the answer I was looking at. The preliminaries starts with this. In cosmetic dentistry, the patient is not coming to you with pain. They are coming to you with a desire. They are coming to you with a certain expectation. And only if you think you can fulfill that expectation should you get into cosmetic dentistry. Patient expectation is the foremost point to be taken into account when you're planning any kind of aesthetic dentistry. If you think you can't, then you absolutely be careful. Of course, then comes diagnosis, treatment planning, and diagnostic wax-ups, right? Because all of this allows you to plan your aesthetic case. And in patient expectations, this is a slide that I love to put in: always under-promise and over-deliver. Because only when you make sure that you are able to achieve the goals that you have promised to the patient will you be able to succeed in aesthetic dentistry, right? So what's your diagnosis? That's something that is very, very important. The treatment planning part is what becomes the mainstay of successful aesthetic dentistry. And here again, patient priority, where health and function are the first priorities, and then aesthetics, always. Function and then aesthetics. The rules of aesthetics, the tooth soft tissue or the pink white harmony as we call it, and visualization of this using various softwares. So just look at how exactly does this work. Right, we basically go from big to small. That is from the forest to the trees. Right, that is from face to the teeth. So we start with the facial analysis, go to dentofacial, hard and soft tissue, color analysis, occlusion, and then apply all of these beautiful terms in planning our aesthetic dentistry. Right. So let's start with a simple case that I like to show. I'll show you two cases. Why treatment planning makes a big difference in the way that you will deliver aesthetic dentistry. Now, what do you see in this patient? What's the immediate concern you think the patient came with? Yeah, obviously, this anterior crowding. But the patient didn't come to us only with that. The patient also came with a problem of discomfort in these teeth, right? And when we took, I'll show you the next X-ray, you can see this is how the overlapping was. You can see the full mouth images there, and this is how the patient came into us. Now this was a young software guy, around 26 years old in Bangalore, and he came into us with a little bit of discomfort along with this complaint, right? And his main concern was actually the discomfort, not just the overlapping of the teeth. But look at the X-rays. And what do you see in the X-rays? On those two centrals. Yes, can you see there is clear caries and there is periapical lesion, but this was not visible in the initial overlap because of the overlapping. Now the patient had a main problem with pain, not just with their overlook, but both were his concerns. And how would you plan such a case? What would you basically do? What would be your treatment options? Yes, I think there are very few answers, so you can definitely help us out in that. Yeah? So what would you plan for such a patient? Obviously one plan, which is what the patient wanted, was root canals and then crowns, right? So that you can do the crowns and you can possibly even correct the malocclusion there. But once we counseled the patient, now this was at a time when, Invisalign was not yet even available in India. And we discussed with the patient didn't want fixed braces, the patient wanted something that would not be seen, and only then would he be ready to correct the teeth, otherwise he wanted instant orthodontics, which is cutting the teeth and doing the root canals. So we counseled the patient, he was ready to go to US to a partner of ours and start with the Invisalign. He started the Invisalign, and as you can see, over a period of time, we not only started straightening the teeth, but also did the root canals to cure him up over there. So this was interdisciplinary going on at the same time, and as you can see, this is what we ended up with. We ended up with straight teeth, root canal treated teeth which are cured, and minimal intervention on the tooth structure. That is what we started with, and this is what we ended up with. So as you can see, this is what we started with. Simple. This is the patient's natural teeth, just closed with restorations, and this is what aesthetic dentistry is about. Not just doing massive fancy tricks, but giving the patient functional, minimal intervention occlusion. And now I'm telling you this, and the next case I'm going to show you exactly the opposite. Look at this particular patient. What do you see over here? Same concern? Yes? Overlapping, central and lateral, right? And what would be your treatment plan? Overlapping, central and lateral, we took impressions of course, but this is a patient from Korea, right? And she was here just for a week, right? And obviously, then we can't go ahead with orthodontics. So there, what do? We pivot to the other side of aesthetic dentistry, wherein we do instant orthodontics, which is, but there was not just again a problem here that when we just cut the tooth. The tooth also had a sinus opening there where we had to do root canal. So we did a root canal, as you can see in this area, right? You can even see the lateral canals being filled up. Once this is done, then we went ahead with the correction of the smile over there. And as you can see, we started with this and we ended up with a natural smile barrier there, giving the patient back her natural smile in a matter of few days, right? So that is what is possible in treatment planning, and that's why it's so important to plan your treatment before you get into aesthetic dentistry, right? So all of these are things that we need to take into account. Again, I'm not going to go into the specifics, I'm not going to go into the theory, but we're going to look at more of cases. The next, of course, very important part in this is diagnostic wax-ups, right? Because diagnostic wax-ups help you to plan your entire treatment right from the beginning, show the patient that treatment and deliver that treatment to the patient, right? So you can have diagnostic wax-ups in various kinds, right? And various types of smiles that you can copy in the diagnostic wax-up to show it to your patient, right? You need to make the various steps in making a silicon index if you're doing additive. I'm sure we are running short of time. I've been asked to do it a little faster, so I'll try to run over these. So as you can see, we can plan in additive dentistry, we can plan the diagnostic wax-ups, deliver that to the patient, and then check how exactly that can be done, right? Or for example, if you're doing just two teeth, you can just even have a diagnostic wax-up and check both the frontal as well as the lateral looks and deliver that to the patient over there, right? But what we are also moving towards now is digital mock-up, wherein you do a complete digital change of this entire area and then you scan this and then deliver that to the patient itself. The next part of the next supporting role, because before we go into the main roles, we see these few supporting actors that I'm looking at. To see, you need two eyes. That is, to do cosmetic dentistry, you need to look at two specific eyes. And what are those eyes of ours? One is isolation and the other is good impressioning, right? So isolation has become one of the mainstays of good cosmetic dentistry because we all know that cosmetic dentistry relies highly on bonding. And bonding without isolation is nothing but just quackery, right? So if you do not isolate well, you will not be able to bond well. This is a kit I prefer to use because it's very versatile and you can, use it over multiple areas. The regular clamps plus what you should be adopting in your aesthetic practice is the use of brinker clamps. Because brinker clamps are beautiful when you want to go over the gingiva and you want to retract a little bit of gingiva to get your complete fit of your artificial or indirect restorations, right? So various steps in putting in the rubber dam and achieving isolation, just to show you a model. And look at how lovely we have nowadays, wonderful, colorful rubber dam sheets which make your aesthetic dentistry so much more fun and so much more visually appealing, right? So if you're going to do aesthetic dentistry, you need to know about inversion of the rubber dam. You can see the difference I put in of one where the dam is inverted and where the dam is not inverted, and you will see the difference in the isolation that you will get as well as how you will visualize the tooth itself. Also, you can adopt various ways of putting the clamp, either directly over the tooth or over the tooth where you've not punched. Multiple ways that you can isolate to improve the way that you deliver aesthetic dentistry. And the other, of course, eye is impression, right? And of course, the mainstay today is elastomeric impressions, but we are fast moving towards intraoral scanners, right? And in elastomeric, of course, the mainstay is double mix. The double mix, double impression technique. I have slides on showing you how exactly that is done, right? You have various techniques and doing the double mix impression technique. I think we don't have the time to go into each of those steps, but this is how your final impression should look when you have a aesthetic case. You should not be seeing the putty. You should be seeing the light body whenever you're capturing an impression over there. But of course, these are the two intraoral scanners that I'm working with now. One is of course the iTero and the other is the RUAS, right? We've been using these and they give very, very good results in terms of capturing the various kinds of aesthetic procedures that we're planning to do, right? Also very important, not just two eyes, but we moved into the third eye today, and the third eye of course is magnification and along with that photography. While we are moving towards loops for the regular use in aesthetic dentistry, we also have these new cutting edge technologies like a digital scope, right, which is a minute camera that you can attach on your handpiece and in real time look at it on a real screen when you're working in a highly magnified image, so that gives you absolute precision as to when you're doing your endodontic in your cosmetic procedures. Also, photography of course is a very, very important part, but separate chapter itself to discuss, so we'll not go into those details. And another thing that is often ignored in modern cosmetic dentistry is the use of retraction, right? We often forget that these minutiae, which are generally not discussed, are what adds up to elevating your cosmetic dentistry to another level, right? All of us discuss the regular part, the veneers, the crowns, the inlays, but these are the minutiae that make sure that that works, right? Even if you are using digital impressions, you need to have good retraction because otherwise your digital impression will not capture it very well. And even in retraction, from the earlier core techniques, we can move on to something like diode lasers, right? That is where we've gone a step ahead now in retraction. Believe me, the use of a diode laser makes your impressioning and your capture so much more better because you're controlling the blood, you're controlling GCF, and at the same time, in literally a matter of seconds, you're getting your entire margin ready to be captured with a simple diode laser. So you can see the impressioning we've done over here with just a diode laser versus a cord, and you can see the beauty of the impression that you can produce once you use a laser over there, right? The other topic that is generally often ignored, and I see this very often, not just among my postgraduates, clinicians, and a lot of practitioners, is the fact that we often forget to temporize. And temporization often makes the difference between good and great cosmetic dentistry, right? You have to temporize, especially for veneers, inlays, crowns. You have different methods of temporization, right from spot etching to making temporaries directly from the impressions that you have, or as you can see in this particular situation, you remove the restorations, you can take the temporary before itself, and then once you've done the preparation, you have the temporaries ready to deliver almost immediately, right? But not just that, we also are now moving into digital with temporaries, where you have 3D printed temporaries, where you can immediately model the temporaries and then place that completely onto the patient's mouth, right? So looking at these few basics, right, as I told you, we don't have the time to go into all of the basics. So looking at these few basics, let's now finally play our Olympic Games, which is look at the main stars of the Olympics. And in that, the first is what I would like to talk about is bleaching. Yes, it often sounds like a topic which is generally, very simple. But believe me, it is highly underrated in its delivery of cosmetic dentistry, because most patients who come to you for cosmetic dentistry are afraid of their teeth being cut, right? And aesthetic dentistry is something where the patient does not have a need as such in terms of pain or anything. So how do you exactly motivate them to do that? I think the first step that starts in a lot of aesthetic dentistry is bleaching. If you can bleach and show the patient what kind of aesthetic dentistry you can deliver, patients are highly motivated to go ahead for the next step. We find them ready to go in for orthodontics to straighten teeth, because now their whiter teeth are more visible. We see them more interested in taking the change or the next step to build and making their smile better, because they can see the whiteness of their teeth and they want to improve on that, right? Just to start with a simple story, and I think cosmetic dentistry, that's the beauty, in dentistry, aesthetic dentistry is unique in being completely about stories. It's about people, it's about their wants, it's about their needs, it's about how it changed their life, right? Now look at this young lady who came into us, ready to get married in a week, right? She came in with these teeth and she told me, "Doctor, can you do something about the color of my teeth," right? She had been referred because she had heard about treatments from other places, right? So she came in to us and we told her, "Yeah, sure, we can explain all the treatment plans and everything, the different options," and she decided to start with a simple bleaching, right? And then we decided to go ahead with a in-office bleach. As you can see, we placed in the bleach over there, and this is the final difference that you can make over there. We started with nearly an A3.5, we ended up with an A1 shape. When we gave the patient the mirror after this bleaching process, she literally started crying. And I was like, "Oh my God, have you done something wrong?" Right? And then she looked at me and told, "Doctor, this is something that I just did not expect. These are tears of joy." Not just after the bleaching did she call me and make me a VIP at her wedding, but also the fact that she sent her husband, her mom, her to-be husband, her mom and sister to us after that to make sure that all their smiles matched hers, stands as a testimony to the fact that how simple procedures can change the way that you put in cosmetic dentistry to the patient, right? So this is what we started with, as you can see, and this is what we ended up with. Another patient that I'd like to talk about is a son of a very famous politician from Bellary, right? I won't name the politician. He is going in for the movies and he was undergoing orthodontic aligner treatment, which is the current trend, right? Because of his fetish for going in for the movies. But during this orthodontic treatment, his one tooth became dark and he was devastated, right? Because this tooth became dark, he had to act in the movie and he was shocked that something like orthodontic treatment can do this to him. Of course, it was because of the fact that the orthodontic treatment was unregulated and done by not a qualified person. So once he came into us, he told, "Doctor, I do not want to touch the tooth. I do not want you to cut it at all," right? That's how particular he was about the sanctity of his tooth. So of course it needed a root canal, but after that was done, as you can see, we would have done a non-vital bleaching over there. And once the non-vital bleaching is done, I choose the slide changer. So you can see that once that was done, we got back to this smile, and the patient was extremely ecstatic because he could go back to his regular routine without the tooth being affected. So this is what simple things can do. Now for bleaching evaluation, again there's a checklist that you have to follow. Again, we would not go into the details, but what I'd like to emphasize, if you're planning to do bleaching, and believe me, whenever I do these workshops on bleaching, I see the fact that I'm really glad with the fact that these are procedures or treatments that clinicians can adopt in their practice the very next day. I get lots of messages where doctors tell me that we have started this almost immediately onto the patient. And that is what I feel is about aesthetic dentistry. It should be actionable. It should be something that you can implement almost immediately, right? So you can do all of these, but what I like to emphasize is that when you're doing bleaching, you have to change that shade guide completely, right? From your regular shade guide, you will move and rearrange this classical shade guide to a value-based shade guide rather than a hue-based shade guide. So you will move from, your shades will start with B1 and go up to C4, and you can see A4 is somewhere in the end over here, not over here. Why? Because this entire thing now is based on value. Can you see the difference? How it is moving from the lightest to the darkest, which is what you want to check in your bleaching. So that is the shade change that you will show to your patient when you are doing bleaching over there. And of course, bleaching is one of those few aesthetic procedures which you can elevate to the next level. It's one of those very few procedures where you can make the patient feel as if they've come to a spa, because of the simple fact that the entire experience can be made so much more better, right? This is the bleaching timetable that I'd like you all to know, right? Because you should be informing this to your patient. The various materials we can use, there are so many materials which shows that the popularity of bleaching is growing day by day. There's hydrogen peroxide both in office and take home. There's carbamide peroxide, again in office and take home. There's materials for non-vital bleaching, for microabrasion, right from the classical mechanisms to opal luster, and there's the latest one on the market, anti-wet, which we use for fluorescent stains, and along with that, the in-office, the take-home methods. And of course, we have various lasers and lights that we are using in aesthetic dentistry, right? So for example, night guard bleaching, simple case like this, as you can see, we deliver the entire area there, and you can see that patients like these, when they come in, you can end up with these kinds of color changes. And for example, a patient like this who comes in will be motivated to get an entire area changed in just 10 days once the color is changed because of this particular bleaching technique. Right? In office bleaching, of course, you can see we can get multiple changes just in a single visit from A3.5 to A2. And this is a patient that again, another patient who flew into us from Switzerland. And she came in just because of the fact that she had heard about the bleaching process. And she came into us telling, doctor, I visited the entire world and I haven't been able to get a shade that I want. The bleaching just doesn't work for me. And we explained the various options to her, told her what are the drawbacks, because bleaching, even though it sounds like a very simple science, is highly complex because of the fact that you have to tell the patient about things like translucency, you have to talk about incisal edges, you have to talk about the various color changes that will happen and that will not happen, right? We did a session, 3 sittings, not 3 sittings, 3 applications of 20 minutes each. You can see that this is the bleaching process, and this is what we started with, and this is what we ended up with. And again, when we handed the patient the mirror, she started crying, right? And I was like, oh my God, have I again done something wrong? And then of course she told me, no doc, this is something that I never expected was possible, and this is how exactly I wanted my teeth to look, and that is the smile that she went back with to her country from a simple aesthetic procedure, right? So that's what bleaching can basically do. But the story here does not end. This patient came back to us after 3 years with a relapse of the bleaching, because bleaching can over a period of time go back to the original color. So she flew back all the way from Switzerland just so that she can get the bleaching done again with a touch-up, and you can see in just one session we went back to the original color that we had started with, right? So various studies on bleaching, a systematic review and meta-analysis that shows that it's a scientific procedure with long-term applications and a high effect on patients' quality of life, right? So various methods of bleaching, various cases that I can show you, but we'll just look at a few and then we'll go into the next one. We've also done a lot of light-assisted bleaching. We can use these like Beyond, which is approximately a 3 lakh machine, so it's pretty much expensive, but no longer available. Or you can use something like the Zoom, which is the Mercedes of bleaching, right? You can use this machine and then go ahead with your bleaching and in a single session produce changes that are excellent. But of course, lasers have made it far more easier to bleach nowadays with their bleach tip, right? You have specific ones. As you can see, a bleaching in this area, just simple 20-25 minutes. and you can produce these kinds of changes in the patient's mouth, right? So bleaching by itself, microabrasion techniques, right? Various steps in microabrasion, of course, to remove fluorescent stains, and various commercially available ones to remove the stains permanently. So all of these are procedures that you can use. And in fact, we are one of the few clinicians to start with something that has recently been launched in the market. It's not even launched, it's still in its trial phase, and we were asked to give an opinion on this. It's an automatic bleaching kit with the light placed in the office. As you can see, it's an inbuilt light along with the application, and you can see that just with a single application, you can go from A3.5 to B1 with these kinds of bleaching techniques. Then coming to the next, right, I look at a few aesthetic techniques. If we have the time, we look at how many ever we can. The next one is aesthetic recontouring. It's something that is often, it's not even heard of in bleaching, in aesthetic dentistry. But believe me, just with simple techniques, you can change the way that the patient's smile looks without being highly minimal or not harming the tooth. Now, what can you see over here? The patient came in with a concern of the incisal edges, and all we did was recontour those incisal edges. That's the only thing that we did over here. So something as simple as this can also change the way that the patient smiles. Then of course we come to the mainstay of aesthetic dentistry, that is both direct and indirect restorations, the various materials, light skewing techniques that we use, right? You can start with anterior restorations like these. You can do them either freehand, or what we've started doing now is more with the silicon index, the putty index which we use, or even simple class 5 restorations that can make sure that you deliver aesthetically pleasing restorations. This is where blinkers, clamps, as well as your cords will help you in delivering good success. Peg laterals, which can be easily healed with beautiful composite restorations, right? Or even diastema closures, something that we get very often nowadays, right? So all of these are things that can be done. Multiple diastema closures, class 4 restorations, as you can see, they can be etched, bonded, and with bonding you can produce completely aesthetic results in these areas. Or of course, as I told you, you can use the putty index when you take an impression, prepare that, take in the bonding, and complete the entire restoration, right? Putty index along with the shade match, use the button technique for shade matching, you build up the entire thing and you complete this entire process. And there are lots of research onto this which shows that the putty index is a more reliable method of building up your class 4 restorations, right? So you elevate your cosmetic dentistry in these areas. Posteriors, of course, you might think that posteriors you can give anything, right? But believe me, posterior shade matching is something that is an art by itself, right? For example, these failing amalgam restorations, once you remove them, isolate them well, and you remove the restoration there with the use of proper mattressing, because mattressing is very, very important in posteriors if you want good cosmetic dentistry. You might give a perfect shade match, but if you do not create the contour and the contact, which is possible only with sectional mattresses, you will not get long-lasting aesthetic dentistry, right? So you produce that and you can complete the entire process and go ahead with your finish of your cosmetic restorations, right? Caries like this with sectional mattresses, all of that can be produced with your cosmetic dentistry with composites. The main thing about composites that I'd like to emphasize is the fact that the use of composites has to be mastered. Even today, I see that there is a lot of confusion on how much time to etch, how to remove the etchant, how to put the bonding agent, how much time to apply the bonding agent, whether to agitate it or not, which generation. So all of those are steps that will elevate your cosmetic dentistry only if you have mastered it. And you have to read a specific material because each material has its own requirements, right? So composite veneers, you can have composite veneers, right? I'm not a big fan of them, but then in some cases the patients would need them because of possible financial issues, so you can produce cosmetic ones like these. Or of course we go to the mainstay of modern cosmetic dentistry, which is the Instagram veneer videos, right? That is what everybody wants to see. So ceramic laminate veneers can change the way that the patient looks, right? We have various veneer designs, of course. the favorite, the one that I believe works best, even according to most articles, is now using the incisal design, right? Where you just end the incisal edge rather than creating a lap, because sometimes the chamfer can create a thin edge of the enamel which might break. So you have to be selective about the cases that you do and what kind of restoration you do over there, right? For example, look at this patient who came into us, right? What do you see over here? Sorry? What do you think is there over here? Chlorosis? Yeah, this guy was a chef in a very famous school, a Canadian International School, I'm sure Stonehill and Canadian International, is a chef over there from Australia. And he was here over 2 years, and he came to us with this. And what do you think he had? These were composite veneers that were done long time back and have over a period of time discolored. And you can see how thick they were and how they have changed over the period of time. Now, once we remove those composite veneers, you can look at what we were seeing over here. A lot of discrepancy, a lot of tooth that have already been removed. So you have to work under these conditions to change the way that the patient looks. So first we give him the temporaries, you manage, you look at the occlusion, you look at the various finish lines, and then finally you can see that from this stage, we went up to this particular stage. That is, we started off with this, and we ended up with veneers on all of those anteriors up to the premolars and changed the way that he smiles in this area, right? So a lot of research on the longevity of veneers with systematic reviews being done regularly, right? You have the various steps in the veneer, this thing, of course, I think we are already close to finishing of time. So various steps in veneering, and of course, what is being adopted now is digital smile design in dentistry, in veneer designing, wherein you can use it for multiply designing the various veneers and then delivering it according to the patient, right? Now this is another patient who came into us, a female, and she came into us with this kinds of teeth, right? What do you think? Guess the etiology is what I've written over there. I would happily give a free meal to somebody who guesses the etiology. What do you think caused this? What do you see over here? Bruxism, okay. Good guess. Reflux, yes, very good guess. This is getting interesting. A lot of nice ideas. Anything else? I'm sorry, we don't have much time, so I can't give you too much time to guess. So, what do you think was this? Now, this lady had a peculiar habit of biting into bricks. Right? She loved eating bricks, actual bricks. I couldn't believe that the first time that she told me. She loved eating bricks. And this was what the bricks had done to her teeth, completely worn them out. And only after a lot of counseling did she decide that she wanted the teeth changed. But we told her that you'll have to give up bricks for that, definitely, right? Because if you're going to put our veneers, we don't want to eat bricks with that. And then she agreed to it. She went through a month of not eating bricks, and that is when we started with the procedure. And as you can see, once we completed the entire veneers, she just wanted veneers for the front 4 teeth where her smile is visible. And that is what we designed with the smile designing, and you can see it's the final decision. You can see this is what she came in with, and this is what we finally gave her with, right? Aesthetic smile and a brick-free life. Right? So that's what you can have with your patients, right? You can have additive veneers. When you add veneers, these are one of the more easier cases to do with veneering because you can add veneers very easily, right? And you have a lot of articles which talk about additive veneers, wherein the veneers are built up over a period of time and given the final finish, right? Then coming to inlays, onlays, overlays, all of these wonderful fancy terms, right? Where you can use either indirect composites, right, to build up your inlays, right? Again, I'm not a very big fan of indirect composites. I prefer ceramics because of their longevity. And you can do ceramic inlays in this case. You can see how easily and beautifully you can get all occlusion as well as complete finish. And all of these are ceramic inlay cases, as you can see. Once you integrate them, you can't even see that the inlay is present in that area, right? And the kind of carving that you can achieve with ceramic inlays is wonderful. You can see that the lab work that you can get with ceramic inlays, the detailing and the entire finish that you can get with the ceramic inlay is lovely to restore teeth which are badly mutilated, right? You can have this kind of finish on the ceramic inlays which completely integrates into the tooth itself, right? So various cases of ceramic inlay, unfortunately I would like to speak about each step, but I overestimated the time. So these are all the simple things that we can do with aesthetic dentistry. But aesthetic dentistry is not just related to restorative dentistry, but also endodontics, right? Who would think that endodontics has restorative dentistry or aesthetic dentistry, right? But endodontics and the use of aesthetic post and cores is the mainstay of delivering good aesthetic smiles, right? For example, look at this patient who came into us. What do you see over here? I think it's pretty straightforward. Yeah? What do you see over there? What's there over there? Yeah, the patient came into us with a broken tooth. And not only a broken tooth, he came into us with a ready diagnosis and treatment plan. Doctor, my tooth is broken, put a crown. Yeah, he was very, very clear, right? And then we told him that let's take an X-ray and see what exactly has been done, right? And when we took the X-ray, you can see this is the kind of root canal that the patient had. Not only was the main canal not noticed, there was an additional canal created and some beautiful fanciful pins also that were put in. Maybe the dentist was creating artwork on a radiograph, right? And then we located the actual canal, completed the entire process, and then went ahead with aesthetic post and cores, right? Glass fiber posts along with full ceramic crowns. And why is that important? Because if you do metal posts, then you do not get the aesthetics that you would want from a full ceramic Emax crown. Right? So this is the kind of finish that you can produce with aesthetic post and cores. This is what the patient came into us and this is how we finished his entire smile over there. Right? For example, multiple areas, broken teeth like these, you have to go with aesthetic post and cores. And the other importance of aesthetic post and cores is that they are not just aesthetic, but they are highly functional because I believe that they preserve one very important thing that you cannot get with cast post and core, which is isolation. We spend so much time during root canals to completely isolate the tooth and clean that area, remove the bacteria and then recontaminate it when we are doing cast post, right? But with glass fiber post, you can isolate it under the rubber dam and make sure there is no contamination during your entire process. And then you complete this and you end up with a smile. Another patient who came in with a completely disfigured tooth, as you remove that, do the root canal, complete your post and core, you can see we can end up with these kinds of smiles in this particular patient. So cast post and cores are something that have to be elevated to glass fiber posts along with the finishing of the smile itself. Of course, we are using now CAD-CAM and CEREC, right? One of the hospitals I work in has a CEREC machine along with the CAD-CAM. So the CAD-CAM machine is the CEREC 3 which we have used over here for designing of various prostheses. As you can look at this crown here, there has been a recession as well as an exposure of the margin over there, and a simple CEREC designing of this can allow you to give this in maybe around 2 hours. We can deliver this to the patient itself. Or a failing inlay like this, right? You can prepare it and complete a CEREC restoration in a matter of few hours in this area with just machine milling and copy testing. Or you can even do CAD-CAM endo crowns which give you lifelike appearance in that area and complete the process there, right? Also, all ceramic crowns are easily done nowadays with the scanning as well as the complete finishing with the digital, where you complete the preparation and you complete the entire area with a digital workflow, right? Also very important is restoring the white-pink balance, wherein we do things like gingival depigmentation to make sure that the gingiva matches the color of the tooth itself, right? And using interdisciplinary approach, as we discussed in those rings of Olympics, the interdisciplinary approach wherein you match the gingival zeniths along with crown lengthening to make sure that the smile is aesthetic, both tooth and the white and the pink, right? Then coming towards the end of the process, we also look at facial aesthetics as a completion of the entire aesthetic procedure. And facial aesthetics, believe me, is something that is growing very fast. It is something that I believe ultimately as dentists we will all have to adapt to, especially things like lip fillers and the use of Botox for these kinds of high smile cases, right? And of course, what we are moving now towards is the move of digital dentistry. And there, the latest advance that has come in is the use of facial scanners. Now, facial scanners have become a hot topic, especially, it's already present everywhere abroad and is slowly making its way into India, especially with the availability of this MediSmile one, which is already available in India now. And these work, as I told you, on both photogrammetry as well as on stereo photogrammetry. But that's not the only two. They also work on light-guided scanning, and they also work on laser scanning. So there are different types of face scanners that are already available with different technologies, and there are so many articles that are exploring how facial scanners can be integrated into the modern cosmetic dentistry, right from altering the face profile with orthodontics to giving you the shade match, communicating to the lab as to what kind of look you want on the patient. All of those are things that you can actually do with a three-dimensional live video with your face scanners, right? But not just that, it doesn't stop at that. What exactly are we moving towards is the integration of these face scanners along with the intraoral scanner, the STL files of the intraoral scanner, the photogrammetry files of the facial scanner, and a CBCT file are all getting integrated to produce a 3D printed prosthesis, right? That is what the direction that we are moving into, and believe me, there are still lots of areas here for you to explore and as well for you to research, because there is still no set protocol to mesh all these three together. Even though we have these three beautiful technologies, most of the studies still show that to put them together, we are still looking at a lot of research and a lot of effort in this area. So once this gets together, you will have nearly perfect delivery of smiles to the patient, not just intraoral smiles, but facial smiles, right? So that is what we are moving towards. We are also moving towards artificial intelligence. Yes, there is a lot of talk about this term, but believe me, it's not yet reached the point where we can still completely, adapt it seamlessly into practice. But it is slowly helping us in designing the smile, which is where its biggest function is right now, right? The designing of the smile itself is what AI is doing very, very well, right? So lots of articles again on the use of AI in dentistry and in smile designing is something that we've been using now, right? And to end on a lighter note, right? A lot of high-tech dentistry happens, but believe me, cosmetic dentistry is not just about high-tech, but about the smaller things like this tooth jewelry, wherein patients come into us wanting simple tooth jewelry to enhance their cosmetics, right? You can have somebody who comes in who wants tooth jewelry to match their wedding dress, or you can have a model who comes in like this. These are not photos that we took, these are photos that she sent us from a professional photo shoot because she wanted the tooth jewel to be highlighted on her canine there, right? And various kinds of simple tooth jewelry that can enhance cosmetics. And of course, if you want to go a step further, you can also incorporate tooth art into dentistry, right? Very few takers for this, but it's there, right? So coming to the end of today's presentation, as you can see, Olympics is a long thing, and we've tried to cover that in 45 minutes, pretty much a difficult process to do, but all of the work that the athletes do over years together is for this one gold medal, right? But all the work that we dentists do day in and day out, every smile that we recreate is a gold medal for us. It's a gold medal for us, it's a gold medal for our patients. So we are Olympic athletes every day because we are winning the smile and the cosmetic challenge every day. We are elevating our cosmetic dentistry. These are a few of the places where I work. Thank you so much for being such a patient audience, especially during lunchtime. Difficult time to see away. So thank you so much. Questions are always welcome, and you're free to contact me both on my email as well as on my phone number. Thank you so much one and all. Once again, I would like to thank RUAS as well as NAM and ICD for this wonderful opportunity. Always a pleasure to meet Shiju sir and his wonderful hospitality, and he's one of the best people I have met. And thank you so much, ma'am, for this opportunity. It's an honor to speak in front of you. You're a fountain of knowledge, and it's great to be in front of both of you. Thank you so much, everyone. I'd also like to thank my friend Sunil for giving me this opportunity to be over here. So thank you once again, everyone.
Thank you.
Thank you, Dr. Darun. It was a wonderful symphony of ideas that you put in such a short period of time. I'm sure all of them have truly enjoyed the whole show, I should say. And yeah, it's very, very satisfying. Aesthetic dentistry is very satisfying to the patient. They're almost ready to fall at your feet. No matter how much you break your back with good endodontics, I think it's this that satisfies the patient. And good endodontics satisfies the dentist. Any questions from the audience?
I think the main question on everybody's mind is what's for lunch.
No, there is
So when you said functional, when you said English and non-English, for example, when you said functional, in what sense are you talking about functional? In terms of the occlusion load that the English takes?
So when I talk about function, I talk, of course, in every part of cosmetic dentistry that applies, and I firmly believe, I mean, everybody has different thought processes, but I firmly believe that if you cannot deliver cosmetic dentistry with function first in mind, then don't do the cosmetic dentistry. Because it is always, aesthetics will always follow form and function. I do not believe that form and function should follow aesthetics, right? So if you're talking specifically about inlays, onlays, right? So I would always prefer to go with a specialty or with a proven restorative protocol rather than doing something that is not yet proven over the long 5 or 10 year protocol. As you would have seen, there's a lot of trend towards onlays or even tabletops, right? But until the bonding technology has been proven over 5 to 10 years, right, we still are looking at giving aesthetic dentistry which can last, right? So in inlays, of course, it means the ability to take in maximum biting forces.
Okay, sir. Because I was just thinking, if there was an inlay given on a patient with chronic bruxism, how would the inlay work even if it was strong enough?
Well, if
would the load be
now
negative?
parafunctional habits is a totally different topic to discuss in cosmetic dentistry, right? As you saw, there are patients here which we've seen who have parafunctional habits, and how we address them makes a big difference. So that would be a different discussion itself in terms of how parafunctional habits have to be addressed before we go ahead with the restoration there, right? But because the patient has a parafunctional habit, you can't deny them a restoration, right?
So one more, sir. You had shown the midline diastema, and there was a workup done on the diastema case. What if that case of midline diastema was a papillary penetrating cranial attachment, or if it was spacing, which was due to other factors, and that you would just...
What I will try to discuss is, 45 minutes of aesthetic dentistry. It would be a pleasure to discuss this in so much more detail, because each patient, as I told, is a different story, each analysis, and that is why the treatment planning is what makes the whole difference. If you have, for example, a frenulum attachment, or if you have a frenulum test that is positive and you need to change that first, you will incorporate that into your aesthetic dentistry, which is where you will start balancing pink and white, right? You will look at both function first. Again, you pretty much reinforced what I was saying. The fact that you have to first look at function. You have to remove the etiology of the cause of the diastema and then only treat the diastema. Right? So therefore you will first remove the cause. If the freedom is if the hyperactive freedom is what is causing the problem, you will first treat that. Right? And we have lasers to do that very easily nowadays. And then you will go ahead with the next step, which is closing the diastema.
One last question, sir. Just the staining that occurs due to food. We as Indians take a lot of food material that has inbuilt stains in that. But that's a part of our diet, right? So would someone would come with that kind of a complaint to you, what would you suggest them?
So cosmetic dentistry is something that does require a little bit of cooperation from the patient, right? Just like any other part of dentistry. So if the patient is ready to change or do that slight change in their habits, then of course you can go ahead with cosmetic dentistry. But if they tell you that no, we are not ready to change our habits, right, or we cannot stay away from this particular thing, right, then of course you have to rethink, and which is why I talked about, again, we come back to treatment planning and patient expectations in this area, right. If the patient tells you, I'm not going to give up smoking, do whatever you want, right, you're not going to do bleaching for that particular patient, right, or if the patient tells you that I cannot stay away from turmeric, it's my most favorite item, then of course you need to tell the patient that you'll be seeing me more often to remove those turmeric stains. Right? So that's what we need to discuss with the patient there.
Thank you. Thank you.
Just regards, I had a patient where we did composition use a restoration. And 6 months later, she said, I want to change the restoration because it has become discolored. Then case history we took, and she had the habit of having turmeric milk every day on empty stomach in the morning. So once I told her, she got a shock. She said, I didn't think it could affect my restoration. A simple polishing, finishing helped her. But she said she will look into changing her habit.
So we all have beautiful stories to talk about in aesthetic dentistry. That's the beauty of aesthetic dentistry. It was a lovely story. Thank you.
Thank you. So from starting the presentation with lower expectation of a patient to matching the expectation of the audience, thank you so much. And I have a small question, sir. Nowadays we have these restorations with a lot of radiolucent fillers. What happens to the radiographic nerve?
Sorry, I know radio opaque fillers.
Radiolucent fillers. You have signals which are you're looting with your knees or your ears always.
Yeah,
what
so
does it happen?
Well, if you're using most of the materials that are used in modern dentistry by protocol have to be radio opaque, right? So if you know that a particular material is not radio opaque or is not going to be seen, preferably stay away from it. That's the best thing.
Seal is what we use for ceramics or laminates.
So most of the luting cements are radio opaque. They have a good, because that is minimum ISO requirement. You have to be radio opaque to be qualified as a cement that is worth marketing in the market. You have to have specific, otherwise it's not allowed. The ISO requirement is very much fixed.
Will it not overlap or will any KD which is there underneath? Will it be seen? And there is another issue with this CBCT as well.
Of course, yes, definitely. There is a lot of, yes, so that is a grey area in terms of the fact that you have to be, that is where the clinician comes in, which is why as yet in cosmetic dentistry, as I told you, there are so many areas where AI cannot take over. It cannot. Something like, for example, a retraction. You cannot do it with AI as yet. You still have to do it manually or you have to use a particular method. So same thing in your CBCT analysis, you have to be able to differentiate between the noise, between background radiation, scatter, you have to make up for metallic artifacts or hardening of the beam. All of those are things that will come in when you analyze your CBCT.
We have come across something of protocols for the imagings, if you want to increase or decrease or something.
So yes, there are a lot of work in fact. In fact, a lot of the imaging software itself has undergone a change now in CBCT to make up for these radio opaque artifacts which come in with a lot of restorative protocols, especially in endodontics. Because endodontics, all the sealers we use, the gutta we use, everything is highly radio opaque. So it creates a lot of scatter and it creates a lot of beam hardening, which is what is the term for it technically. Now beam hardening, the first thing that they are doing is a change in the software, the acquisition software, as well as the iterative imaging. The build-up of the imaging, they are using iterative focusing, which requires a lot of computing power as compared to the earlier method where you do build-up of the imaging. And along with that, what they are doing is they are using very simple tricks. You know, there is something called as a trick where you can use cotton on the restoration and it will reduce the beam hardening at a particular point. So you need to be able to place it in a particular area and it will change the way that the CBCT acquires the image. Something as simple as that to high-tech change in the software.
Because these are the things which are required for the day. Because as we are going to the advancement of the technology, we tend to have a lot of noises.
Absolutely, you're absolutely right. And I think it's very important for the younger generation to be aware that every technology comes with its own drawbacks and we need to know how to use it in the way that it favors our final result.
Thank you, sir. I would request Sylvia ma'am and Mr. ma'am to please kindly.
Seed bagru.
I request Sylvia sir. I request Sylvia sir to hand over the certificate of appreciation from our director. Sylvia Matthew. Now that you have finished with the session, I request
Good afternoon to one and all. Respected dignitaries, esteemed judges, distinguished guests, dedicated participants and valued attendees. It is an honor to stand before you again as we conclude this inspiring International College of Dental CME and Scientific Medicine. Today we celebrate not only the culmination of the CME but also the creativity, dedication and hard work that each participant has demonstrated. To bring this event to a close, I welcome the dignitaries on the dais. As the phrase goes, in the world of medicine, learning never truly ends. The CME program has reminded us all that continued education is not just a requirement, but a responsibility we owe towards our patients to provide the best care to them and improve the patient outcome. At this moment, I would like to invite Dr. Yogesh Kumar Virmani sir to share his thoughts and perspective on today's CME and Scientific Fest.
Well, sharing a thought, I thoroughly enjoyed the whole process right from the morning, and I think I sat through all the 3 lectures when we were there. Dr. Ajay Chaudhary was wonderful. Even for us, he gave us so many eye-opening things. And Dr. Deepika is a totally new subject which has come up in AI. And again, our Dr. Dharam, his lecture was very good, but he fell short of time. So overall, Dr. Banda, the whole organization went very, very well, and we are here for the inclusion, and that also on the time. So that is also a big thing whenever you organize a thing, that you are able to manage the time well. So my congratulations to the whole organizing team and
Your support and involvement have greatly contributed to the success of this event. Dear delegates, we hope that today's CME and Scientific Fest have left a lasting impression on you. We are interested in hearing how our efforts have met your expectations. We encourage the participants to share their feedback on the event. So I call upon Dr. Sanjana Shetty to share her views.
Good afternoon, everybody. I'm Sanjana Shetty, an intern at Faculty of Dental Sciences, Ramaiah University of Applied Sciences. I'm very glad to be able to share my feedback on this conference. Firstly, I want to start off by saying how lucky I feel to be a part of Ramaiah University of Applied Sciences, where so many great events and conferences are happening in-house for us. It's so convenient in multiple ways. I'm sure all the delegates who are from Ramaiah relate to this. And for this, I would like to credit Dr. Om Prakash Kharbanda, because I believe since he has been on board with us at this university, these events have only increased in number and giving us multiple opportunities to present here. And since I started my BDS journey here at Ramaiah, I have been to multiple conferences at Manipal, Mumbai, Kanyakumari, Goa, and so on. And I should say this conference is on par with all of those. Absolutely, really well organized, and also the food was really great. I need to mention Dr. Silju Matthew, the Dean of our Faculty of Dental Sciences, who's always supportive and motivating to attend these conferences. I've heard from my friends in other colleges that this motivation is not there everywhere. You know, they're always pushing us to participate, pushing us to present, and I'm really grateful to that. Thank you so much. I would also like to mention that the e-poster presentations were conducted in a really innovative way. I haven't seen it being conducted like this anywhere else. It was really interesting to see that it was very aesthetic, and I would like to credit the scientific committee for it, especially Dr. Dominic. Speaks for itself. Any dilemma, anything, sir was always there to help us out. Dr. Soumya as well and Dr. Sunil here. Everybody was super supportive throughout this. So, and I have to mention the talks that have been happening here since morning were from our very eminent speakers, were really interesting and insightful into multiple things, the aesthetic, the orthodontic surgery, everything was very well presented, and I really liked it. Thank you so much for organizing this conference. I know 100 hands went into this, and I'm grateful to everybody over here for that. Thank you so much. Okay. My suggestion for an improvement in the future would be, this was a one-day event with one pre-conference workshop which happened yesterday, which I forgot to mention earlier, was also conducted meticulously. But I would suggest that this conference be held over a span of 2 days maybe, and spread out the events so that there's minimal overlap, and so that we get to see everything. Like we are able to attend the talks as well as attend the poster presentations and the quiz. I'm being greedy, I know, but if it was held over 2 days, I think it would have proceeded even more smoothly. And also, adding on to the pre-conference workshops, we had one this time, laser workshop, which was yesterday. If we have multiple such pre-conference workshops, then I think it would be really helpful for us.
Thank you, Dr. Sanjana, for providing a thoughtful feedback. Your input is greatly appreciated, and we take it into consideration. Dr. Dominic and his scientific session team has played a crucial role in guiding today's scientific event and overseeing the selection process. These professionals have not only managed the logistics but have also contributed to their expertise to create a stimulating and enriching environment for all the participants. With great pleasure, I invite Dr. Dominic to take over the stage to begin our presentation.
Distinguished guests, dear colleagues and friends, as we come to the close of this remarkable conference, I stand before you filled with a deep sense of gratitude and fulfillment. This conference has been a testament to the power of collaboration, in this case between ICD, NAMS and RUAS, and definitely the pursuit of excellence. The diversity of topics covered, the depth of analysis presented, and the passion with which each speaker and participant shared their work are reflective of the vibrant community we are privileged to be part of. I am confident that the knowledge shared here will continue to resonate and catalyze innovation long after this event has concluded. I would like to take this moment to extend my heartfelt thanks to all the participants from the institutes in and around Bangalore. To mention a few: Government Dental College, Bangalore, KLE University, Krishnadevaraya College of Dental Sciences, Manipal College of Dental Sciences, and CSK Teja Institute. I would now like to announce the session-wise awards for the best e-poster presentation, and I request Dr. Y.K. Vimani sir and our Honorable Pro Vice Chancellor, Dr. O.P. Karbanda sir, to give away these awards. So for session 6, we had 6 poster sessions, and we have a session-wise award. So for session 6, the best e-poster award goes to Ms. Varsha Reddy and Sanjana Ramesh. In session 5, the best e-poster award goes to Dr. Nitya Sachdeva from Manipal College of Dental Sciences.
Anyone from our college is here? Please pass it on.
From session 4, best e-poster goes to Dr. Amrita Singh, Faculty of Dental Sciences.
My topic was adoption of whole slide imaging in routine diagnostics.
But maybe you were very active at that time with them. Am I right? You were there that time?
Yes, sir.
So you were competing, sorry.
Session 3 Best E-Poster Award goes to Dr. Archie Rai, Manipal College of Dental Sciences. Session 2 Dr. Sanya Shetty, MCOS Manipal. Session 1, Best E-Poster goes to Dr. Sanjana Shetty and Dr. Sai Prasad.
Our topic was early detection of oral submucous fibrosis via MATLAB-based identification of hyalinization.
So we have one special award, that is the overall best e-poster amongst all 6 sessions. And the overall best e-poster award goes to Dr. Archie Rai from Bangalore. I request Dr. Soumya to announce the paper presentation awards.
Good afternoon, everyone. To move on with the paper presentation awards, the best paper for session 1 goes to Dr. Nitya Ganeshan from Faculty of Dental Science. The best paper for session 2 goes to Dr. Vinodini from Krishna Devaraya College of Dental Science. The best paper award for session 3 is shared by Dr. Mukul Saini and Dr. Vikas B of Faculty of Dental Sciences, Ramaiah Medical College. And the overall best paper award goes to Nitya Ganeshan of Faculty of Dental Sciences. Now I would like to call upon Dr. Hajira Khatun to announce the winners of the quiz.
The quiz was indeed a battle of wits and knowledges, but finally we arrived at the prizes, and the third prize goes to N. Tisha Srivarsha and team, who has wrote to Ramachandran and Shreya S. Maybe invite Dr. Indresh sir on the dais. He is the quiz master. He has arranged for the entire quiz. And the second prize goes to Taha Siddiqui, Samantha Shivkumar and MD Dia from Faculty of Dental Sciences, Ramaiah Medical College. backed by Tanmay Sharma, Harshita Harlalka and Shubham Agarwal.
I now invite our organizing chairman, Dr. O.P. Kharbanda sir, to deliver the closing remarks.
At this juncture, I don't know what to say, except that I express my happiness over the events that have occurred last 2 days, and they have been really full of scientific flavor and the enthusiasm, equal enthusiasm from the participants and also from the speakers and the faculty. One thing I wish to add here, in order, that for the last few months or couple of years, we at FDS and RUAS have developed a very cohesive group of people who have started thinking alike. And with this synergy of virtues which each one of them have, together we are able to do it. If I say that he is more important than the other, I don't think I can differentiate, because each person has played his role to his best, whether Dr. Sunil or Sejal or even Dominic. Or I would say, when I was discussing with Sunil and other people, that please ensure that our technical staff, our photographic staff, our cleaning staff, everyone should be part of the team. They should be together, and I think it is that spirit which has made this happen. The second thing I wish to tell you is that, and we were students, I joined dentistry in 1972. That time we used putting in. And I don't know if you know, how many of you know how putting in works. Putting in works that you have to run the wheel with the foot, and with the mirror you are looking at left upper 7 and left upper 15 and also doing the drill. And that was time there was no concept of visualization was not there. Only boilers used to be there. We used hand instruments to cut the hand. But I wish to tell you, the quality control we learned dentistry was much higher than today. And how do I say quality control was higher? Because we made dentures that time with compo as a primary impression material, alginate as the ultimate material. But between the two there was a concept of border molding. And till our border molding of the muscle attachment was not perfect to the extent that we leave that specialty in the mouth, both upper and lower, and our supervisor used to come and ask the patient, say 66, say Mississippi, say this, say to blow your nose, then spatial tray should not fall. That was the test. And I wish to tell you that whatsoever dentures I made after graduation, I never had to do anything. I never had any problem, because we knew how to record the centric, what is the freeway space. That was the quality control. We did castings with gas, and we used to do ourselves, melt the metal, gold, then it used to go into the ring, there was a spring loaded device, and there was a cast, and we used to break the inlay, take out the metal, clean it, quench it, deliver the inlay, and the inlay that was delivered is for lifetime. And similarly, if we had to do silver filling, we had to go for outline form, resistance and retention form. Proximal walls have to be parallel. Base has to be flat. Pure surface angle has to be obtuse. And when we fill up the silver amalgam in a class 2 cavity or class 1 compound cavity, it has to last for lifetime. Because with time, silver expands. With time, composite shrinks. Because of the corrosion which copper and silver would have, it will become more tight. Because when you fill first time, the micro space between amalgam and the wall is 40 microns. Bacteria is 1 micron. Slowly it expands and seals. So that is the kind of quality control work here. Because our teachers were trained. My teacher was a captain in army, British Army, operative person. Our prosthetic professor has worked with buckets, and also those times the functional occlusion concept came, growth function, canine protector in 70s. Brittner's experiment on how the TMJ reacts when it first touches, there is a trauma. So those, I'm talking of those days. Now what I feel, what is happening now, that the quality control is missing. The quality control is missing. We are in a hurry. I don't know what hurry we have, but we all are in a hurry. So my humble request to you is that dentistry is something which is a super specialty. I wish to tell you. What you as a graduate dentist can give to the patient, no other specialty in healthcare can give. Maybe some physiotherapy to that extent, because they also produce some movement, some devices. So you have a bigger responsibility. The second challenge which you have in society is that you need to integrate yourself with the healthcare system. Don't differentiate yourself. And if you want to be part of healthcare system, you have to have the knowledge of all those diseases, and you should be able to use those terminologies to communicate with your healthcare professionals, which they expect you to know. So if you have saliva, somebody getting the abnormal smell, you should suspect diabetes. If you are getting abnormal circumoral pigmentation, notice it. If you are finding something different, eruption tooth is getting delayed, note of it. Send it for endocrine consult. Is it hypo? Is it hypopituitary? Hypothyroid? Whatsoever. So this kind of vision, from a regular vision to a broad vision, is very much required. When you focus on your skills, go laterally, think laterally. I am an orthodontist, but why should I be concerned about oral cancer? I am concerned because that is a national problem. So think about those national policies. Where is the, go to the WHO website, see what are universal health coverage, what are the goals of the other goals of the WHO, how they are planning stages in prevention. We only talk of fluoride, mouthwash, toothpaste and brush. Broaden your vision. That is the other request. Now this sermon, whatsoever I gave, was not warranted. I know it is a closing ceremony, it is meant for something else. But somehow I cannot resist telling you all this, because I face this problem day to day. Because I have to come across many patients as a referral, as a third or fifth consultation. Those who have seen my X number of dentists, still there is a problem, so they end up with me. And then I look backward, why this person has missed this. There is no substitute for attention and clinical attention. So that is my humble request to all of you. The other thing I wish to tell you that it is not necessarily if you have become a dentist, you have to practice dentistry. The venues are much more. You can become an entrepreneur, you can become an innovator, you can become a scientific writer, you can become a researcher. You could be anything. So if you have a mind which is innovative, diversified, please take care of the profession. Please do it. And use this profession as a strength to take a jump, springboard to the other things. The Ramaiah group here, Health Sciences Campus, this is Health Sciences Campus, we have Technology Campus. Very, very unique campus. Very few campus have everything in the same place. So we have opportunity to interact with other specialties, different disciplines. Please do interact them. If you have somebody from pharmacy living next door to your hostel, don't think he's pharmacy boy. Talk to him, run over, gossip with him, or gossip with her, anything. What will you gossip? Talk about drug interactions. Talk about what they think about antimicrobial resistance. Talk to the guy from medicine about what he thinks about other diseases. So what you will learn by interaction is much more than what you can learn. That is the other thing which I wish to add. The organization of this particular event has been supported by the National College of Dentists, Dr. Mani, Dr. Veera Verma, also by the National Academy of Medical Sciences and full support of Ramaiah administration. So I am thankful to all of them for giving me this opportunity to work with them and be part of their mission. And I thank my team led by Dr. Sidhu Matthew, Dr. Dominic, Dr. Sunil, and I can say that of course he has been wonderful to be here, and you, all of you, so, and please feel free to give feedback whatsoever. Some of you may not express, but if you don't want to express now, you can email us. Whatsoever you feel, email us. Be frank about it. Like, and that will help us to make the next program better. Enjoy your evening, go home, take rest, and be ready for tomorrow, because tomorrow is Monday. So there is no respite. Wish you all the best. I am truly honored to be here. Thank you.
Your remarks are truly inspiring. On behalf of Ramaiah University of Applied Sciences, we sincerely thank the dignitaries for enlightening us with their enthusiastic remarks. We would like to extend a heartfelt gratitude to our guest speakers for their insightful presentation, which have greatly enriched our understanding, and a special thanks to our judges and esteemed guests whose expertise and thoughtful evaluation have been invaluable in recognizing the outstanding work presented here. A special acknowledgement to the excellence and creativity of all the participants, and we also owe a deep appreciation to our organizers and volunteers for their tireless efforts in making this event a success. As Sir mentioned, from the organizing chairmen to the helpers who have all participated and have helped each other in bringing this event make a success. Thank you so much. I shower my heartfelt gratitude to everyone from the family of Ramaiah University of Applied Sciences for their wholehearted support rendered in the success of the CME and Scientific Fest. A special thanks to ICD and the nuns for allowing us to organize this big event. Thank you so much for all the support. In closing, I'm reminded of a quote by Albert Einstein. The important thing is not to stop questioning. Curiosity has its own reason for existing. Let us embrace this curiosity and continue to push the boundaries of knowledge. With this, I thank you all for being a part of this event. May I request you all to rise for the national anthem.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, and we request you to join us to the tea.